Welcome to video number 5, Pharmacological Interventions for Insomnia, Benzodiazepines and Nonbenzodiazepine Hypnotics. 5 categories of medications have been approved for the treatment of insomnia disorder. These include benzodiazepines, which are GABA-A receptor positive allosteric modulators, non-benzodiazepine hypnotics, which are GABA-A receptor positive allosteric modulators specifically bind to alpha-1 subunit, dual orexin receptor antagonists or DORAs that act on orexin-1 and orexin-2 receptors, melatonin agonists that act on melatonin-1 and melatonin-2 receptors, and H1 receptor antagonists. Benzodiazepines, including triazolam and temazepam, are used for treatment of insomnia disorder, potentiate GABA-A receptor functioning by increasing channel opening frequency in contrast to barbiturates, which increase channel opening duration. As compared to barbiturates, benzodiazepines have a better safety profile. Benzodiazepines increase stage N2 sleep, whereas decrease stage N3 and REM sleep. It is recommended that clinicians use triazolam 0.125 to 0.25 milligram as a treatment for sleep onset insomnia and temazepam between dosages 7.5 milligram to 30 milligrams as treatment for sleep onset and sleep maintenance insomnia in adults. Side effects associated with the use of benzodiazepines include drowsiness, dizziness, confusion, memory changes, muscle weakness, gait instability, and falls, particularly in the elderly. If prescribed, short-term use is recommended due to risk of tolerance, rebound insomnia, withdrawal, and dependence has been associated with the use of benzodiazepines. Tolerance is defined as reduction of a drug's effect with repeated administration of a constant dose, or the need to increase the dose to sustain a specific level of effect. Rebound insomnia is defined as worsening of sleep relative to the patient's status before starting treatment. Rebound insomnia can last for 1 to 2 nights after the hypnotic medication is discontinued. It is more likely to occur with hypnotic medications with short and intermediate half-lives. Rebound insomnia must be differentiated from withdrawal syndrome, which is characterized by a new cluster of symptoms which were not present before treatment that are unpleasant and last for a few days to few weeks rather than 1 to 2 days. Withdrawal symptoms occur generally with long-term use of hypnotic medications. The risk of dependence with benzodiazepine hypnotics is increased with chronic use of shorter-acting hypnotics at higher dosages, a history of substance use disorders, personality disorders, and lack of medical supervision during medication prescription. The non-benzodiazepine hypnotic medications approved for insomnia disorder include zaleplon, zolpidem, and S-zopiclone. The short-term efficacy of non-benzodiazepine hypnotics is well established in terms of significant improvements in sleep quality and sleep latency. Additionally, wake after sleep onset time, total sleep time, and sleep efficiency also improve depending upon drug's duration of action. The elimination half-lives and duration of action of the non-benzodiazepine hypnotics range from short-acting zaleplon to moderately short-acting zolpidem and intermediate duration of S-zopiclone. Differences in pharmacokinetic profiles can be used to clinical advantage in the treatment of insomnia disorder as patients with sleep onset difficulties or morning sedation from hypnotic use may benefit from a short half-life drug, and patients with sleep maintenance difficulties may benefit from a drug with a relatively longer half-life. Zaleplon 10 to 20 mg is recommended for management of sleep initiation insomnia. Zolpidem 5 to 10 mg is indicated for management of sleep onset insomnia. Sublingual formulation of zolpidem has been approved for the middle of night insomnia, provided that individual taking this medication has at least 4 hours of sleep time at night. As zopiclone 1 to 3 mg for sleep onset and sleep maintenance insomnia has been recommended. The efficacy of non-benzodiazepine hypnotics for up to 6 months of nightly or intermittent use has been established in double-blind placebo-controlled studies. These medications appear to have low potential for abuse and dependence, but like benzodiazepines, these medications are scheduled class 4 medications. Rebound insomnia and withdrawal symptoms occur infrequently upon discontinuation of non-benzodiazepine hypnotics and may be less common and milder than those seen upon discontinuation of benzodiazepine medications. Relative contraindications to the use of non-benzodiazepine hypnotics include severe pulmonary failure, untreated sleep apnea, hepatic failure, alcohol or substance use, and use of other sedative drugs. Side effects include dizziness, anterograde amnesia, confusion, and hallucinations. The most common adverse event reported in adults is headaches. Complex sleep behaviors are complex activities normally associated with wakefulness that occur when the patient is in a sleep-like state after taking a hypnosedative drug. When the patient awakens the next morning, the patient has little or no memory of the activity. Complex sleep behaviors include sleepwalking with object manipulations, sleep conversations, sleep driving, sleep sex, and sleep shopping. Evidence suggests that complex sleep behavior risks may increase with both the dose and binding affinity at the alpha-1 subunit of GABA-A receptors. A number of potential strategies are available to manage and prevent hypnosedative-induced complex sleep behaviors. These include lowering the dose of or stopping the offending hypnosedative agent, examining drug regimens for potential drug interactions, and assessing concurrent alcohol use that may predispose patients to experiencing complex sleep-related behaviors. Other strategies include treatment with other classes of medications, using non-pharmacological treatment strategies for insomnia disorder, and careful selection of patients for treatment to prevent the likelihood of such adverse effects. Key points: benzodiazepines including triazolam and temazepam, and non-benzodiazepine hypnotics including zolpidem, eszopiclone, and zaleplon are recommended for treatment of insomnia disorder. These medications act as positive allosteric modulators of GABA-A receptor, with non-benzodiazepine hypnotics specifically acting at alpha-1 subunit of GABA-A receptor. Triazolam and zaleplon are effective for sleep initiation insomnia, whereas zolpidem, eszopiclone, and temazepam are effective for sleep initiation and sleep maintenance insomnia.